Hi, welcome to the Amyloidosis Research Consortium webinar. My name is Omar Siddii. I am a cardiologist at the Boston University Amyloidosis Center, and I specialize in seeing patients with cardiac amyloidosis. On behalf of the Amyloidosis Research Consortium, it's our pleasure to welcome you to this webinar. Today, I'm going to be giving you an overview of ATTR cardiac amyloidosis, what the disease is, how do we diagnose it, and a little bit about the biology of this disease process. What is amyloid and amyloidosis? So first, some definitions. Amyloid is the protein fibril. And amyloid is actually a descriptive term to describe the configuration the protein takes in tissue. The disease that the amyloid protein causes is amyloidosis. So amyloidosis is the disease, amyloid is the protein. You can see on the right-hand side is a little cartoon that describes the process by which your body makes proteins. And these proteins adopt certain configurations. So this functional native protein looks something like this. And then for whatever reason, environmental factors, genetic factors, the protein breaks down into various configurations and can form disordered aggregates or can form these beta-pleated sheet structures, which are amyloid fibrils that can deposit in organs. And these misfolded proteins can deposit in various organs like the heart, the kidney, the nervous system, and they can disrupt organ function. Now, you may be aware of a couple of different kinds of amyloidosis, but actually amyloidosis is not one disease. It's a family of diseases characterized by many different proteins that can misfold. And so far, 35 different proteins have been identified as precursor proteins for amyloidosis. You may have heard the term amyloid fibrils when people talk about Alzheimer's, and the protein adopts a similar configuration in Alzheimer's, but it's a totally different disease process. And when we extract amyloid protein, we can stain it with a dye known as Congo red, and it has a very characteristic appearance under light, which you can see here in these red aggregates. This is a more sensitive way of looking at structure by something called electron microscopy. And this shows you these fibrils and these linear structures, which are fibrils depositing, in this case, in the tissue of somebody with amyloidosis. And what's important for you to understand is that these sticky protein fibers deposit in between heart cells. I'm going to focus on the heart today. They deposit in between the heart cells, and they cause the heart to thicken and stiffen. So unlike other causes of heart failure where the heart pump may become weak, in amyloidosis, the heart pump becomes stiff because of all these sticky proteins that are depositing between the cells, kind of gumming up the cells and causing injury to the cells. There are two major types of cardiac amyloidosis based on the precursor protein that leads to this process. I said there were 35 different precursor proteins, and a lot of them can cause cardiac amyloidosis, but there are two major proteins. One is a disease called ATTR or transthyretin amyloidosis, and the other, also very important form, is AL or light chain amyloidosis. It is imperative that we rule out light chain amyloidosis when we are diagnosing somebody with TTR, because light chain amyloidosis can be rapidly progressive, rapidly fatal, and needs to be treated very quickly. And with effective treatment, people with AL light chain amyloidosis actually can do very well as well. We're going to focus for the rest of the talk on ATTR transthyretin amyloidosis. This protein, this disease has two flavors as well. You can have a genetically abnormal or variant or hereditary form of the disease where you are born with a mutation in the transthyretin gene. And so the protein that's produced is abnormal and inherently liable to misfold and form sticky fibrils. This doesn't happen when somebody is young, but it usually is a disease of aging, and this genetically abnormal protein will misfold and deposit in various organs. The more common type of ATTR cardiac amyloidosis is the non-hereditary or wild-type TTR. And that's where the transthyretin protein is genetically normal, but it accumulates as people get older in the heart, soft tissue, nervous system, etc. So a little more about transthyretin amyloidosis and the transthyretin protein. All of us have transthyretin protein. It's made in the liver and it circulates in the body. Another name for transthyretin, abbreviated TTR, is prealbumin. So your doctor may check prealbumin levels on your blood tests, and prealbumin is actually the transthyretin protein that leads to ATTR amyloidosis. The name tells you what it does. So trans is transport, Thi is thyroid hormone, so it's a transporter for thyroid hormone, and retin is retinol. So transthyretin is transport protein for thyroid hormone, and retinol, which is vitamin A. Vitamin A helps you see in the dark, and it's helpful for normal functioning of the eyes. It turns out that the thyroid hormone is also transported by another transporter, so transthyretin is not a major player in thyroid hormone biology, but it can be important in transport of vitamin A. And so in people who are being treated with certain gene silencers, for example, we might supplement them with vitamin A so that they have enough vitamin A in their bodies. Okay, so this is to tell you how the disease forms, and this is to give you a little bit of an image to illustrate the pathobiology, the biology of the disease. So all of us have a liver. All of us have a liver that makes this transthyretin protein. The genetic code is translated into protein. The protein adopts what is known as a tetramer. Tetra means 4, so 4 subunits that you can see here. And this is the stable form of the protein, and this is where the thyroid hormone binds and vitamin A binds and all of that. And this protein circulates in the blood in this shape of a 4-leaf clover, a tetramer. Now, for some reason, either hereditary reasons or environmental reasons, this 4-leaf clover, this tetramer can break down and form dimers, like 2 subunits, or break down further to form monomers that can misfold and form these sticky fibrils that then deposit in the heart, causing a restrictive cardiomyopathy, causing stiffening of the heart, or they can deposit in the nervous system, causing a peripheral neuropathy. So this is actually the process by which the disease causes problems in patients. And this is important because we're not going to talk about treatment today, but this is how we think about treating ATTR amyloidosis, where we can intervene at various points in this progression. So why does transthyretin misfold? I told you that it circulates in the body in its normal state as a 4-leaf clover binding to thyroid hormone and vitamin A. Why does it misfold? Well, we know that in people who are born with the mutation, people who have hereditary transthyretin amyloidosis, that genetic mutation predisposes them to having an unstable structure that can then break down as they get older. So that, I think, makes a little bit of intuitive sense. But the vast majority of patients with ATTR cardiac amyloidosis are going to have wild-type or genetically normal protein, and we actually don't know why it folds. It's a process of aging, we know that, and we know that there is a male proclivity. So males are more likely to have ATTR wild-type cardiac amyloidosis. But beyond that, we actually don't know what causes the transthyretin to break down and misfold. Now, a few things that are important for you all to know as patients is that ATTR wild-type amyloidosis causes congestive heart failure. Because the heart becomes stiff and thick, the heart has to fill with blood, and it fills with blood at very high pressures. And the high pressures are transmitted back to the lungs, causing shortness of breath, back into the belly, causing your belly to swell up, down into the legs, causing swelling or edema. Also, because of the stiffening of the heart cannot fill very well because it fills at very high pressures. So if you go out for a walk or you climb a flight of stairs, the heart in a normal situation has to augment cardiac output. It has to pump more blood to your exercising muscles. But when you have a stiff heart, you are less able to do that, and that accounts for the exercise intolerance in patients with heart amyloidosis, where they have a really hard time exercising. Important to know that ATTR amyloidosis is not a heart attack. Heart attacks are caused by blockages in the blood vessels of the heart, the coronary arteries. This is not what we're talking about here. It is not a cardiac arrest. The heart doesn't stop circulating blood. The heart is still pumping, but it's just filling at a very high pressure. So heart failure is a situation where the heart inadequately circulates blood to meet requirements of the body. So you can have low cardiac output, or in the case of amyloidosis, more commonly, it does so at a very high pressure. And so that high pressure backs up into other organs and causes problems. So your signs and symptoms, we talked about shortness of breath, particularly with exertion or lying flat at night. You can have a lot of leg swelling, abdominal bloating, weight gain. You can develop lower blood pressures, which could be because of the heart failure, but also because of the nervous system that controls blood pressure can be affected, the autonomic nervous system. A lot of patients complain of a lot of fatigue and weakness and the need to take naps during the daytime and low energy. So these are all common symptoms of heart failure and particularly ATTR cardiac amyloidosis. We can also see heart rhythm problems. The heart has an intricate electrical conduction system, and when these protein fibrils deposit in the electrical system, they can cause short circuits that can cause arrhythmias like atrial fibrillation or atrial flutter, or arrhythmias from the bottom chambers of the heart called ventricular tachycardia or ventricular fibrillation that can actually cause the heart to stop and the person to die. You can also get slowing of the heart rate, known as bradycardia, or various kinds of conduction abnormalities called heart block. In these cases, we may put a pacemaker in patients, and that can restore their normal electrical functioning, and the patient is going to feel a lot better. So this is, as physicians, as cardiologists, this is where we think about heart amyloidosis, ATTR cardiac amyloidosis, in patients who are presenting with heart failure with preserved ejection fraction. So heart failure meaning they have shortness of breath, extra fluid on their body, but their heart squeeze is normal. That's the preserved ejection fraction. And on echocardiogram, heart ultrasound, they have increased wall thickness without there being another reason for them to have increased wall thickness, like high blood pressure. In patients who are of African descent, we know that certain populations have a higher prevalence of gene mutation. So for example, in people of African descent, those patients, about 3 to 4% of that population may carry a genetic mutation known as V122I. And that predisposes them to amyloidosis, particularly as they get older, over the age of 60, and they can also have a peripheral neuropathy. If somebody has a heart failure with preserved ejection fraction and a peripheral neuropathy, numbness and tingling in their fingers and toes, autonomic neuropathy, that's where we think about amyloidosis. Autonomic neuropathy means an inability to regulate blood pressure. For example, when you stand up, you can get really lightheaded and dizzy. These patients can also have a lot of GI problems like diarrhea, constipation. The other thing we see is the heart rhythm known as atrial fibrillation, where the top chambers of the heart just kind of quiver instead of beating nice and sequentially, is very common in this disease. And those patients are at high risk for having blood clots that can cause strokes. So anybody with heart amyloidosis with atrial fibrillation, we put those patients on a blood thinner like apixaban or rivaroxaban or warfarin, etc. The other common scenario is patients who have carpal tunnel syndrome in both their wrists, or they have other soft tissue manifestations like spontaneous biceps tendon rupture, and that's called the Popeye sign, because when you flex your arm, the muscle kind of bunches up spontaneously, and that's also caused by wild-type amyloidosis, ATTR. So how do I diagnose it? You can actually do a tissue biopsy, like a heart biopsy, or you could take a bit of abdominal fat and you can stain it for Congo red staining, and that tells you if there's amyloidosis. The vast majority of patients that we will encounter will have ATTR wild-type amyloidosis, but we also have to perform genetic testing to rule out the hereditary form. And it is imperative to make sure the patients do not have AL light chain amyloidosis. So we have to rule that out. So we have to identify the presence of amyloid deposits either by biopsy or nowadays by non-invasive scanning, something called a pyrophosphate scan, a nuclear medicine scan that can tell you if there's ATTR amyloidosis in the heart. We have to make sure the patient does not have AL amyloidosis, and then we perform gene sequencing to make sure that they have wild type and not hereditary disease. And this is our basically algorithm in 2025 for diagnosing amyloidosis. It's actually borrowed from a paper written by Dr. Kittleson and my mentor, Dr. Ruberg in Boston. So we are clued into amyloidosis by the patient's history, by their shortness of breath, by their symptoms, by the EC echocardiogram. Sometimes we'll get a cardiac MRI to take a look at that. And then we rule out the presence of a monoclonal protein AL amyloidosis by running some blood tests. And then once we've ruled it out, then we do like a pyrophosphate scan, a nuclear medicine scan to figure out if they have ATTR. If they do not have a light chain disorder, if they do not have a monoclonal protein, and we know the patient does not have AL, then we go down this pyrophosphate scan, PYP scan, the nuclear medicine scan, and this tells us if they have amyloid, ATTR amyloid or not. And then we go from there and we perform genetic testing and we try to see if they have genetically normal or abnormal protein. So in summary, cardiac amyloidosis is not one disease. It's a family of diseases characterized by infiltration of misfolded protein fibrils in the heart. The most common kind is ATTR wild-type cardiac amyloidosis. That's the most common kind. Can be hereditary, variant, or wild type, where the genetic type is normal in wild type amyloidosis. And amyloidosis is characterized by a stiff and thick heart, causing the heart to fill at very high pressures and causing congestion, shortness of breath, fluid in the lungs sometimes, fluid in the belly, fluid in the legs, and an inability to exercise. You can also see arrhythmias, atrial fibrillation, etc. You can see aortic stenosis, so you can see valve disease. Carpal tunnel syndrome is very, very common, as are other soft tissue manifestations. So with this, I thank you for attending this ARC webinar, and please contact us with any questions. Thank you very much.